Good evening, everyone. Thank you so much to the team, the top course team, for giving me this opportunity. And I'll be discussing a few uh, tips and tricks on the drugs, the fluids, and the instruments that might be asked in your practicals. So, we will always be confused with what to read because there is so much to read in terms of drugs. Some people might write notes or make notes right before the exam, and some people might just leave, in fact, this particular station. So I've divided this topic into cardiovascular agents, antibiotics, sedatives, analgesics, and other essential classes. We might not be discussing in detail about each one of them. However, what I want you to remember is whenever you all answer any of these, this will be your star slide. That is the mechanism of action, indication, contraindication, adverse effect, dosing, and evidence. And if need be, we can also mention regarding the half life, the route of administration, and the drug interaction. This is the first question. What is this drug? If you're given this drug, how are you going to describe it? Okay, this is the vial that you're given. Okay, so this, first of all, is a vial of atropine sulfate. It is a 20 ml vial. Uh, it has 8 milligram per 20 ml, and it is an anticholinergic. That is the mechanism of action. Indication being symptomatic bradycardia, AV block till definitive treatment. It is also used as an antidote for cholinesterase poisoning or cholinergic drugs. It is contraindicated in case of pyloric stenosis, glaucoma, prostatic hypertrophy. Adverse effect being it causes dilated pupils, dry skin, tachycardia, tremor, ataxia, delirium. And the dosing is 0.6 milligram IV bolus every 3 to 5 minutes in case of a bradycardia, maximum being up to 3 milligram. For OP poisoning, we give 2 milligram every 15 minutes until atropinization. What is atropinization? Nowadays, we don't see other things. We only see how the tongue is or the pupils are, whether there is dilation of the pupils or not. And and it can also be given via ET. This is the second drug, which is the adrenaline. It comes in an ampule of 1:1000, that is 1 milligram per ml. Mechanism being it acts on the beta-1 receptors, beta-2 receptors. It decreases the systemic vascular resistance, causes bronchodilation, and there is some minor activity of alpha-1 receptor as well. Indicated in case of cardiac arrest, ACLS, shock. Okay, it improves the cardiac output. Type 1 hypersensitivity reaction, anaphylaxis, stridor refractory asthma as a part of local anesthetic. There is no absolute contraindication. However, might be relative contraindications in case of closed ankle glaucoma, arrhythmias, pheochromocytoma. Adverse effects, it can cause metabolic acidosis, hyperglycemia, tissue ischemia, and the dosing being it can be given in the form of IV during CPR, 1 milligram every 3 to 5 minutes as mentioned in the ACLS guidelines, as nebulization during asthma, and also during anaphylaxis, the dosing being 0.5 milligram IM for adults or 0.01 milligram per kg IM in case of children weighing less than 30 kg. All right. The third drug, we have noradrenaline. Does anyone want to describe this based on the headings that we have given? Any takers for this? Okay, so the mechanism of action being alpha-1 adrenergic action, it causes peripheral vasoconstriction. Beta adrenergic action, it has inotropic action, but there is no beta-2 activity. It is used in case of septic and cardiogenic shock, hypovolemic shock, basically different types of shock. Adverse events, it decreases the end organ perfusion and affects bradycardia, increases the afterload. Dosing, we all know this is 8 to 12 microgram per minute with maintenance being 2 to 4 microgram per minute. All right. And evidence, it has an evidence in surviving sepsis campaign which strongly recommends the use of norepinephrine over dopamine due to lower incidence of arrhythmias and potentially improve mortality outcomes as given in the SOAP2 study. We should also remember that this ampule, it comes as a 2 milligram noradrenaline tartrate, which contains a 1 milligram noradrenaline base. So these are two different. It is coming as a bitartrate, but the base of noradrenaline 2 milligram is equivalent to 1 milligram of noradrenaline base. Vasopressin. Vasopressin, this is, so when you're asked in the exam, you have to first mention that this is an ampule of vasopressin injection, which is a vasopressor whose mechanism of action is on V1 receptor, resulting in action on the vascular smooth muscles. It has an antidiuretic effect secondary to V2 receptors, and it also causes ACTH release by acting on the V3 receptors. Indication: septic shock. It decreases the noradrenaline requirement. Vasodilatory shock after a cardiac surgery. In case of variceal bleed, hormone replacement in case of brain dead donors, and in case of central diabetes insipidus. Following which, we need to talk about the adverse events and the evidence. The evidence being coming from the VAST study and the VANISH trial. It itself doesn't have any difference in the survival or mortality improvement unless it is used along with noradrenaline and also along with hydrocortisone. It is seen to have some survival benefit. Next, we have an inotrope, that is dobutamine. So these, you might be given these vials of dobutamine, and you have to describe it as an inotrope whose mechanism of action is on the beta-1 adrenergic receptor. It increases the cyclic AMP and enhances the contractility, and it has some beta-2 adrenergic receptor activity as well. Indications: acute decompensated heart failure, cardiogenic shock, and supporting of the cardiac function while the other underlying causes are addressed. It is also used in case of stress testing. Next comes the dosing, which is 2.5 to 20 microgram per kg per minute. And we need to talk about the side effects and the complications. In some cases, you might be asked evidence of these drugs as well. So I've made tables for each of these drugs, but we'll not be going through all the drugs. I'll just be fast forwarding these slides. So you can take screenshot of them or you can read them later. So we have norepinephrine, vasopressin, dopamine, and adrenaline. And please describe these drugs in this format, that is mechanism of action, indications, adverse events, the contraindications, dosing, and the key evidence of these drugs. You might also be asked regarding other inotropes, that is milrinone and levosimendan. You might be given these drugs, and we need to talk regarding the class of medications, that is the phosphodiesterase 3 inhibitor in case of milrinone, calcium sensitizer, as well as potassium ATP channel opener in case of levosimendan. Okay, dobutamine causes much more tachycardia compared to the other two, and there is significant peripheral vascular resistance decrease in case of milrinone as well as levosimendan. So what is the difference of use in all these three drugs? So for dobutamine, you have, when MAP is adequate, it provides a fast inotropy. When catecholamines are ineffective or beta blockage is there, then milrinone is used. And in case of low oxygen demand, inotropy with low oxygen demand and long-term support, levosimendan is used. Please remember the typical doses of each of these. All right. And effect in case of renal failure, milrinone cannot be used because there is prolonged hypotension, and we also need to avoid or be cautious in case of renal failure while using levosimendan. Next, the trials, milrinone, MIDAS trial, and levosimendan, we have the CHEETAH, the REVIVE, SURVIVE, and LIDO trials. So these trials might be asked, and it helps to clinch additional points in case of exam. So question 6, what is this vial? So this is a very much a favorite of all the examiners. The sodium bicarbonate, the mechanism of action of sodium bicarbonate being it dissociates into sodium and bicarbonate, which is consumed by the hydrogen ions, forming carbonic acid, which can further deteriorate into carbon dioxide and water. And it exactly acts as a buffering system to maintain the serum pH and alkalizes the urine to prevent precipitation of compounds in acidic condition. Dosing. Now here we have to know, when we are given in the exam, please check which percentage we are given. Is it 7.5% or is it 8.4%? Because 7.5% contains 44.6 milliequivalent of sodium bicarbonate and 8.4 contains 50 milliequivalent in 50 ml of sodium bicarbonate. All right. And 1 ampule, we have 50 ml is equal to 50 MEQs of sodium and 50 MEQ of bicarbonate. Uses, it is used in case of cardiac arrest because of hyperkalemia, basically severe metabolic acidosis, where your pH is less than 7.1. That's where it is used. It is also used in case of certain poisoning cases like tricyclic antidepressants, barbiturate poisoning, severe diarrhea with bicarbonate loss, again related to severe acidosis, normal anionic gap metabolic acidosis, and increasing the urine solubility in case of rhabdomyolysis or methotrexate toxicity. FAD is what we call it as. Contraindications, you have in alkalosis, it is not used. Hypocalcemia, hypernatremia, it can worsen a pulmonary edema, worsen fluid overload state, and in hypokalemia precipitated by alkalosis. Evidence, we need to remember or mention the bicar ICU trial, where in severe metabolic acidosis, sodium bicarbonate had no effect on the primary composite outcome. However, in certain substrate of patients, that is, the patients which had a defined acute kidney injury, there was an improvement in the 28-day composite outcome, which comprised of mortality plus organ failure plus use of RRT. So these improved or decreased in case of the renal failure patients compared to the other subset of patients. Another emergency life-saving drug we have is the calcium gluconate. So calcium gluconate, it provides stabilization. It is used in case of hyperkalemia with ECG changes, hypocalcemia, and calcium channel blocker. In case of digoxin toxicity, which is a relative indication, and hypercalcemia, it is contraindicated or should be used with caution. Adverse events, and typical dosing is 10 ml, 10%. All right. We should also remember how much percentage of elemental calcium is present in case of calcium gluconate and in case of calcium chloride. Calcium gluconate has about 9% elemental calcium, whereas chloride, sorry, I've mentioned carbonate here, it has about 40% of elemental calcium. All right. So this is about, see, I'm not going too much into the detail of them. This is just to help you speak something in case of exams. All right. And if you go by this, the mechanism, users, contraindication, you'll be able to answer most of the things. Coming to antiarrhythmics, we have the most commonly used one, which is the amiodarone hydrochloride. It comes in an ampule of 150 mg per 3 ml. All right. And its mechanism of action, it has various mechanism of action. It is a class 3 antiarrhythmic with potassium blocking property. It also has a beta 1 adrenergic blocking it is also a beta 1 adrenergic blocking agent along with calcium and sodium channel blocking activity. Its indication, it is used in case of supraventricular tachyarrhythmias, life-threatening ventricular arrhythmias. I think this will be spoken in detail in your next session, which is by Dr. Priya, and pulseless VF and VT and out of hospital cardiac arrest. All right, it is given in case of cardiac arrest situation, it is given as a 300 milligram IV or intraosseous bolus. And it is given as an infusion of 1 milligram per minute for 6 hours, followed by 0.5 milligram per minute for a total of 24 hours. All right. And contraindication, it is not given in case of second or third degree block, prolonged QTC, hyperkalemia, sodium channel toxicity. And when you have a reversible cause, please try to correct the reversible cause. Side effects of amiodarone, side effects being it causes both hyper as well as hypothyroidism, photosensitivity, peripheral neuropathy, lung fibrosis, all right, which is a serious side effect, but it can be progressive, it can be fatal, liver damage, cardiac depression, and corneal microdeposits. Other cardiovascular agents we have, I'll be speaking a bit fast on this. We have the lignocaine. Please remember, it is not used in Wolff-Parkinson-White syndrome with AF, and the ICU dosing as given in the ACLS guidelines. We remember adenosine, it is a transient AV nodal blocking agent via the A1 receptor. All right, it is used in case of the supraventricular tachycardia, AV NRT with narrow QRS. 6 milligram rapid IV push followed by 12 milligram. What one needs to remember is after giving it, we need to lift the hand. All right, and second thing is please keep there might be a potential for a sudden cardiac arrest after this medication. So one needs to remember that. And it has an ultra short acting half-life of less than 10 seconds. Likewise, magnesium sulfate, it is used in case of indicated in case of torticity pointers, hypomagnesemia related arrhythmias, given as 2 gram IV over 10 to 15 minutes and may be repeated in infusion form. So this is the classification. Please remember the Von William classification. It is a busy slide, I know, but once you read this slide, you will be able to know and answer everything. Vasodilators, please do read about nitroglycerin, sodium nitroprusside, and hydralazine. Sometimes you might be asked, most commonly nitroglycerin. It is a vasodilator. It's indicated in ACS and hypertensive emergencies, as well as in acute pulmonary edema. It causes hypotension. It is not contraindicated in case of an RV infarct. All right. And it should not be used along with phosphodiesterase 5 inhibitors. Headache, hypotension, reflex tachycardia, it might cause methemoglobinemia in rare situations. It is started as a 5 to 10 microgram per minute IV, followed and titrated up to 200 microgram per minute. And the evidence is it improves symptoms and ischemia in case of ACS and overload state. Another cardiovascular agent which is very commonly used is furosemide. I'll not go into the details of it, but what one needs to remember is whenever you are asked about furosemide, please read the ROSE protocol, the resuscitation, optimization, the stabilization, and the evacuation protocol, because that is one question that you might be asked even in your vivas. Mannitol, it is an osmotic diuretic. It raises the ICP, certain toxin overdoses it is used, and it causes volume depletion, hypernatremia, renal failure. It is given as a dose of 0.25 to 1 gram per kg IV over 20 to 30 minutes. So basically for ICP control, we normally use it. And if we are talking about mannitol, we have to talk about what is called as 3% sodium chloride, which is the hypertonic saline. Outside, it is used up to 21%. Here we have the 3% normal saline with sodium content being 513 milliequivalent per liter. It is used in case of symptomatic hyponatremia on raised ICP. If the person has come in a symptomatic hyponatremia, sometimes bolus of 150 ml is started with, followed by infusion and monitoring of the sodium levels. It increases the serum sodium and has less diuretic effect compared to that of mannitol. Osmotic gradient drives the fluid from the interstitial space to the intravascular space, and it also stimulates the vasopressin release from the pituitary and reduces the blood viscosity. So, if we have to choose between mannitol and 3% NaCl, what does the guidelines say, or what does the evidence say? There is no mortality benefit of one over the other. However, hypertonic saline has been found to be more effective in reducing the ICP burden, even though there was no change of the Glasgow outcome score at 6 months in either of the two. While talking about these two, one also needs to know about the reflective coefficient, which is 0.9 for mannitol and 1 for hypertonic saline, because of which it is said to be slightly better compared to that of mannitol. However, no significant difference has been found in most of the studies. Okay, and also please read about osmotic demyelination syndrome in case of overcorrection of the sodium. Coming to the heart failure medications, here the most important ones are the recently used ones, which is the ERNI and the SGLT2 inhibitors. The ERNI, sacubitril, it inhibits the neprilysin, okay, and it increases the natriuretic peptide, bradykinin. Valsartan blocks the AT1 receptors. They have strong evidence in decreasing the mortality in case of heart failure patients, particularly it is used and it has been found in case of paradigm HF trial. All right. And the dosing needs, you all need to know. SGLT2 inhibitors, currently favorite in case of vivas. The dapagliflozin and the empagliflozin. Dapagliflozin is the most common one which is asked. These inhibit the SGLT2 in kidney, causes the osmotic diuresis, decreases the preload and afterload. Evidence being it decreases the hospitalization regardless of diabetes, dose 10 milligram OD. All right. And it is even beneficial in case of non-diabetics. But we need to know the two trials, which is the Emperor and the delivery trial. And avoid in all patients with type 1 diabetes mellitus, previous history of DK, okay, or any condition predisposing to DK, patients who are pregnant, it is asked to be avoided. Should be used in caution in the following scenarios: where there is volume depletion, where the estimated GFR is less than 20, and in case of end stage kidney disease, complicated UTI, or presence of risk factors for foot amputation. Among sedatives, hypnotics, anything might be asked. Okay, propofol, midazolam, dexmedetomidine, haloperidol. What one needs to answer is, suppose we are given haloperidol, please mention that this is uh, an ampule of haloperidol, 2.5 2 ml. 1 ml is equal to 2.5 mg. It is a first generation antipsychotic, butyraphenol derivative, and has a high potency dopamine antagonist activity. It is indicated in case of acute psychosis, delirium, mania, and acute agitation. However, it should be used in caution, especially in cases with QT prolongation, in cases of elderly. Adverse effects being extrapyramidal syndrome, tardive dyskinesia, QT prolongation, torsitis de pointis also it might cause. All right. And one also needs to know regarding the trials of haloperidol, dexmedetomidine, propofol, like the Midex Prodex trial. Then we have the MENTS 2 trial. So these might also be asked in the exams. Neuromuscular blocking agents, I'll run through this. The most common one being cis-etracurium, which has, it is a non-depolarizing benzyl isoquinolinum mechanism, and it degrades by Hoffman elimination, which differentiates it from the other non-depolarizing agents, and it is used in case of paralysis. Our evidence comes from the Rose and the Accurus trial. So this two trials you have to know by heart. No, even though it is not a theoretical question, you might still be asked. This is also another favorite of all the old timers. All right, hydrocortisone. Now, hydrocortisone sodium succinate injection. Whenever you are given, please say this is a vial of hydrocortisone sodium succinate injection. It is 100 mg. It comes in 100 mg vial. It is indicated in case of septic shock, adrenal insufficiency, autoimmune states, in case of community acquired pneumonia, as seen in the Cape Cod trial, COPD exacerbation. Well, if we are asked about dexamethasone, yes, meningitis, severe allergic reaction. Mechanism of action, it inhibits the accumulation of inflammatory cells and prevents cell-mediated immune response. Adverse effects, we need to know: infection, peptic ulcer, myopathy, osteoporosis, hyperglycemia. All right. And we also need to know regarding the dose equivalent of the different steroids, which is hydrocortisone 20 mg, methylprednisolone 4 mg, and dexamethasone 0.75 mg. If evidence of steroids in sepsis, please know the studies. We need to know regarding the different uses in case of sepsis, in case of ARDS, and in case of community acquired pneumonia. The REMAP-CAP trial, the recovery trial, Cape Cod trial, even though I have not mentioned all of them here, but one needs to know regarding these trials. Okay. Our next question is, what is this? All right. So this is a vial of 5,000 international unit per ml heparin injection, which happens to be an anticoagulant. That's mechanism of action is binding to antithrombin 3. It accelerates the inhibition of thrombin factor 10A and also inhibits 9A, 11A, and 12A. All right, and it requires this complex, which is why the clot-bound thrombin is not inhibited. Immediate onset when given IV. Clinical use, as in case of DVT, pulmonary embolism. Treatment was as well as prophylaxis. ACS, sometimes you might be asked the dosing of individual one of them. So please know that. Atrial fibrillation and during pregnancy. Contraindications, any bleeding parameters. All right, it is contraindicated. Monitoring, we need to monitor the APTT levels. All right, the target being 1.5 to 2.5 into control, and the reversal agent being protamine. 1 milligram protamine neutralizes around 100 units of unfractionated heparin. Sometimes you might also be asked protamine sulfate as a drug. All right, so please remember the doses. We have discussed a lot of drugs right now, and I am not covering in detail regarding these, the LMWH, the DOACs, thrombolytics, and fibrinolytics, but please make sure you go up and read these drugs. Altiplase, enoxaparin, dalteparin, So these are certain drugs, tranexamic acid, these are certain drugs which are exam favorites, and we need to know that. Unfractionated, one also needs to know the difference between LMWH and unfractionated heparin, the mechanism of action. We also need to know the intrinsic and the extrinsic pathway of the coagulation. That is something I'm not covering in this. So next we have, this is antiepileptic levetiracetam. Other antiepileptics I have not added in these slides, but levetiracetam I have added because there is a special mechanism that you need to know. Please do not say sodium and calcium channel blocking activity in case of levetiracetam. It has a special activity which it binds to SV2A and it modulates the synaptic vesicle exocytosis, resulting in decrease in the glutamate release. This is important, and in fact, if I ask our DrNBs also, they might not know this mechanism. So this mechanism is something one needs to know. And same, please tell about the dosing. The advantages: it has minimal drug interaction, no hepatic metabolism. It is safe in liver disease, safe in pregnancy, a category B drug. It is indicated in various types of seizures, in status epilepticus, seizure prophylaxis, contraindication, use in with caution or decrease the dose in case of renal impairment. And common side effects one needs to know: fatigue, dizziness, ataxia. Evidence: ESET trial in status epilepticus, levetiracetam is found as effective as valproate and fosphenytoin. In case of brain trauma foundation guidelines, it does not actually mention levetiracetam as the drug of choice. However, it can be used as mentioned in the trauma foundation guidelines. So this comes to the end of the other drugs. Now we have a big topic to cover, which is antibiotics. All right, antibiotics. Again, I'll not be discussing in detail regarding all the antibiotics. We will run through a couple of them. Please know the mechanism of the different antibiotics: the penicillin, cephalosporin, vancomycin, the cell wall inhibitors, the protein, which are the protein synthesis inhibitors, which act on 3S and 30S and 50S. All right, the nucleic acid synthetic inhibitors, metabolic inhibitors, and the cell membrane disruptors like the polymyxin and the daptomycin. Also, you might be asked to draw in the exams whenever you are asked an antibiotic that this is the category of antibiotic. So you should also know that which type of antibiotic group it belongs to, whether it is a concentration dependent, where your goal is to maximize the concentration of the antibiotic, and the PK/PD parameters being Cmax by MIC. All right, or it is a time dependent antibiotic where you maximize the time duration which antibiotic concentration exceeds your MIC. Okay, so you might be asked to draw this even in the exams. Please remember which drugs belong to which category. Okay, and once you remember this, it is easier for you to answer any of the antibiotics. So let's start with this. So this is a vial of meropenem. All right. We know what is meropenem. Meropenem, which is the carbapenem group of drugs. Specifically, if you have to answer, it is a group 2 carbapenem. Okay. Group 2 carbapenem. What is the main clinch of group 2 carbapenem? They have activity against non-fermenters, but they have no activity against MRSA. All right. So regarding meropenem, what other questions you might be asked? All right, so which organisms are not covered by this medication or carbapenem? So you have to mention these: MRSA, VRE, E. faecium, Stenotrophomonas. Okay, in this context you might also be asked regarding CRE, which is resistant to any of the penums or that produce a carbapenemase enzyme. Then this can be followed by a subsequent question on the Amler's classification. While you might not be asked while you might not be asked regarding the details of the Amler's classification, you might be asked that which class the KPC or the NDM or the OXA48 belongs to. So you have to remember these classes: class A KPC, class B NDM, and class D OXA48. These are the most common ones. Okay, and what are the subsequent treatment regimen regarding this? One needs to remember ceftazidime-avibactam for OXA48 is preferred, and we have the newer group of antibiotics like cefiderocol, iravacycline. For NDM, ceftazidime-avibactam does not work alone. It is intrinsically resistant, so you have to add an aztreonam or aztreonam-avibactam. And KPC, we have ceftazidime-avibactam, meropenem-verobactam, and imipenem-cilastin-relebactam. So, whenever you are given this, please do not say Zavicefta. Mention the complete drug, which is ceftazidime-avibactam powder concentrate. It is given. In this case, uh, uh, this is a vial of ceftazidime-avibactam. Ceftazidime being the third generation cephalosporin, which primarily inhibits the cell wall, and avibactam being the beta-lactamase inhibitor, which protects the ceftazidime activity by reversal covalent inhibition and restores the activity against the gram negatives. So these are active against gram-negative bacteria, Enterobacteriaceae, Pseudomonas group of organisms, and can be used in complicated UTI, complicated intra-abdominal infection, HAP, VAP, and CRE infections. Dosing 2.5 gram, 2 gram for ceftazidime and 0.5 gram for avibactam. However, dose reduction is required in case of renal failure, and adverse effects we need to mention. Likewise, we have another drug that is vancomycin. Again, very much a favorite of examiners. It is a tricyclic glycopeptide antibiotic, which inhibits the polymerization of peptidoglycan wall. It mainly covers the gram-positive organisms like MRSA. Okay, it also covers enterococci, MSSA, streptococcus infections. Indications. So indications, we have various indications. Out of these, please do not forget to mention the Clostridium difficile with its dosing, that is 125 milligram per oral. It is the only oral indication for vancomycin, given sixth hourly for 10 days. And the other indications being staphylococcal enterocolitis, endocarditis, staphylococcal infections, skin soft tissue, as well as meningitis. The initial dosage should not be less than 15 milligram per kg. It is given in 2 gram divided dose of 500 milligram Q6 hourly or 1 gram BD. Then, while mentioning vancomycin, one should also know regarding the trough levels. Okay, the therapeutic serum trough level is 10 to 20 microgram per ml, and in this case, you might be pulled towards being asked about therapeutic drug monitoring. So, when is the sample taken for the trough based monitoring? One should know it is just prior to the next dose, ideally within 30 minutes of administration, and it is typically done before the fourth or the fifth dose of the new intermittent dosing regimen. Adverse events, you might be directly asked the question, name a drug which causes red man syndrome, all right, or drugs which cause DRESS syndrome. It is also autotoxic and nephrotoxic. So, subsequent questions for vancomycin being, if suppose the organism is vancomycin resistant, then what are the drugs we have in our armamentarium? Then you need to mention all these drugs: linezolid, daptomycin, tigecycline, dalfopristin, quinpristin, ampicillin. Any one of these might be asked, but most of the time these are asked as subsequent questions. Okay, tigecycline, please remember regarding tigecycline that it comes with a black box warning of increased mortality compared to other antibiotics. So it is avoided in monotherapy in case of severe infections. Okay. Daptomycin. So this is a vial containing daptomycin. 500 milligram is present per vial. It is a cyclic lipopeptide antibiotic active against MRSA, VRE, Streptococcus species. Dosing, we have to remember. Mechanism, it is bactericidal but is not effective in treating lung infection due to inactivation by the lung surfactant. Now, this is the most important point in case of daptomycin. Our next antibiotic, teicoplanin. Please do not confuse teicoplanin and tigecycline. A lot of people do that, and drug dosing. Also, instead of tigecycline, some people write the teicoplanin dose. So do not mix up. You in a high pressure cooker situation, this might happen in exam. Be calm and see which antibiotic you have been given. All right. So teicoplanin, its mechanism of action is cell wall synthesis. It inhibits the cell wall synthesis, and it has a good activity against most of the gram-positive organisms. However, it doesn't have activity against gram-negative organisms and very poor activity against Enterococcus faecium. Indications, like most of the other drugs, you have to tell the indications. The dosing 6 to 12 milligram per kg IV every 12 hours. All right, and followed by the maintenance dose. Common adverse events, it is very similar to that of vancomycin. It also causes red man syndrome, nephrotoxicity, autotoxicity, but less compared to that of vancomycin, and it has an advantage of less frequent monitoring compared to that of vancomycin. Okay. Certain This slide I have included because even though you might not be asked directly, but after being given a particular drug, these questions might be important. That name some anti-pseudomonal antibiotic, name some antibiotics with anaerobic cover, name some antibiotics which are intrinsically resistant to Staphylococcus maltophilia, enterococcus resistant to which antibiotics you can say Vapcope. So this is the mnemonic for it. Anaerobes are resistant to which antibiotic? That is acid, aminoglycoside, ciprofloxacin, imipenem, and daptomycin, and not covered by fluconazole. So this is an antifungal, which will be our next discussion. So it is not what is not covered by fluconazole: Cruzi, Glabrata. This is the Candida, Aspergillus, Mucorales, Fusarium, and Cryptococcus gattii. So this is one slide. Probably I'll say this is one of the star slides. This you have to know invariably. Coming to antifungals, I'll just discuss three groups, that is azoles, polines, and echinocandins. Azoles, it inhibits the ergosterol biosynthesis pathway. Polines, it binds to the ergosterol and disrupts the membrane. And echinocandin, it inhibits the glucan biosynthesis pathway. Okay. So suppose we are given this antifungal. So how are we going to describe it? Right? So voriconazole, it is a type of azole. Please talk about the mechanism of action. Talk about the vial. You can always see the vial and describe, ampule, and describe the ampule, describe what is given and how much ml is there in the ampule. The other questions that one needs to know is it is effective in mucosal and invasive candidiasis. It is a step down therapy for infection with Cruzi and fluconazole resistant glabrata. All right, does it accumulate in active form in the urine? So not effective for urine candidiasis. However, it is the drug of choice in case of aspergillosis, and it can be used in case of mycosis as well. Okay, dosing one needs to remember. It is nephrotoxic as it is complexed with cyclodextrin. So this is another important point that one needs to remember, and not recommended when the creatinine clearance is low. So as we have discussed voriconazole, there are other antifungals. Not going to go through the details of it as we have the next speakers in line. But one needs to know regarding each, especially amphotericin. Any one of these might be asked. So mechanism, as we have discussed in the previous slides, typical dosing, liposomal 3 to 5 milligram per kg per day. It is the first line for mucor cryptococcal meningitis. It is expensive, unlike that of its deoxycholate form, and the adverse events in case of liposomal form is much less compared to that of deoxycholate form. So this difference one needs to remember. Regarding these azoles, fluconazole, a very commonly used drug. Where it is not used, we have discussed in the previous slides. All right, posaconazole, it is a salvage therapy in case of mucormycosis. We have used a lot of this oral posaconazole along with amphotericin in mucormycosis during COVID times, right? And echinocandins, one needs to know that in case of echinocandins, it inhibits the 1,3-glucan synthesis. Enidulafungin, it is one of the most commonly used drug. It doesn't have any liver or hepatic elimination. So that's the reason why no drug dosing is required in case of hepatic or renal dysfunction. All right. Piflucytosine, which is a pyrimidine analog, the most important point here is it is used along with amphotericin B in case of cryptococcal meningitis. So these are the few points that one needs to remember. Regarding fluids, I'll not be discussing in great detail, but suppose we are given this particular fluid. So how are we going to describe it? Right? This is a bottle of 20% albumin. You have to describe 50 ml, 100 ml bottle. It is a hyperoncotic uh, 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 colloid, right? And which helps in the fluid immobilization from the interstitium. Uses of human albumin. It is used in case of basically in case of sepsis and septic shock. However, there is no difference in the mortality between the crystalloids as well as the colloids. Albios trial, there was no difference in mortality, but less cumulative balance in case of Albios trial. Albumin diuresis, there is no proven benefit. As we say, the PAL protocol, there was no proven benefit for it. as studied by the Codman et al. Study. However, it has its advantage in the liver disease uh, post paracentesis patients, especially more than 5 liter. If it is removed, then the standard dosing is to give 6 to 8 grams of albumin for every liter of fluid. SBP, there is an indication, and hepatorenal syndrome, it is used along with terlipressin. So these are the clear cut indications uh, uh, for albumin. It should not be used in case of burn patients. It should not be used in case of traumatic brain injury patients. It has been proven that it has a very high mortality. In case of a subset of trauma patients, in fact, it is said to cause worsening of the kidney functions, as seen in the SAFE trial. All right. So, and it increases the mortality. So, that's what you need to remember regarding albumin. Regarding other fluids, I'll not be discussing in detail, but whenever you are asked a fluid, please start by mentioning whether it is a crystalloid or a colloid. Number one. Number two, what is the osmolality? Number three, what is the composition? Okay, all right, and whether it is used as a resuscitation fluid. Last but not the least, one need to talk regarding the evidence that is present of those fluids. The most common evidences now is with balanced crystalloid, which is the plasma light, and most of the studies did not find any difference in decrease in the hospital mortality, decrease in the RRT use, or uh, uh, difference with the incidence of AKI. However, when we take a composite outcome, then SMART study and SALTED study did find some difference with results favoring the balanced crystalloid compared to that of normal saline. So this is what one needs to remember when it comes to fluids. So we have discussed a lot of things. What I do know is that this is one topic. The next topic is what you use the most, but you read the least. Even drugs one might read, but we really ignore instruments until the last day of our exams. All right. So these are the instruments that one needs to read. I will not be discussing all of them. All right. But the star slide for here is whenever you describe an instrument, please describe first of all what it is, what category it belongs to, the description of the parts, the mechanism and the principle of use, its indications, advantages, as well as limitations. Okay. So we first start with this. What is this? So first of all, this is one of the instruments that is used for the airway, right? It is a McCoy blade. This is a McCoy blade. It comes with the handle. Okay. And then we have the blade, the the tip of which is movable, which is different from that of the Macintosh blade. All right. And it is a curved blade. So what is the advantage of this? It helps in directly elevating the epiglottis, and it comes also with a lever which helps in elevating, and this is not present in case of a Macintosh blade. Less force is required, so it is useful in case of patients with a poor neck mobility. It is also used in case of difficult airway and helps with an improved glottic exposure. Trauma risk is less in the McCoy blade compared to Macintosh. However, the learning curve might be a bit more compared to that of Macintosh blade. Okay. So next questions, just questions we will be briefly discussing. So you might be given a video laryngoscope. All right. The question to be remembered is video laryngoscope versus direct laryngoscope device. What is the advantage of video laryngoscope? It comes with these two studies, that is the device study and the Macman study. The first pass intubation rate was a little bit more compared to that of uh, direct laryngoscopy. However, there is no significant difference between the two. However, video laryngoscope was associated with more life-threatening complications, right? Because the disadvantage of video laryngoscope is sometimes you might be able to visualize, but we might not be able to guide the tube. Next is this bougie or the tracheal tube introducer, right? So the tracheal tube introducer, we need to know the uses. Okay, it helps as an airway adjunct in case of difficult airway situations. However, whether the use of a bougie or a stillet, the stillet trial or the bougie trial did not show any difference between a bougie versus a traditional stillet in case of emergency intubation with respect to first attempt intubation control. All right. And if we have to talk about the potential harm, we can injure major structures like the trachea. Last, we have the Goodell's airway or the nasopharyngeal airway. Please remember, it is not given in case of awake patients. We need to describe the parts of it, which is it comes in color coding. Okay, depending on the sizes. There is a reinforced bite block. There is a rigid kink resistant curve which pushes the tongue, and the importance of the size is that if it is too small, if it is too large, it might block the posterior pharyngeal wall or the tongue. Okay. And please know how to measure it. It is from the angle of the mouth until the neck, the mandible. Please do not say tragus. Okay, please do not say tragus. Please, it is the angle of the mandible. So this is regarding the Goodell's airway. The most important instrument that is used in our ICU, which is your endotracheal tube, which is the infraglottic airway device. Okay. If you are asked to describe the parts, you have to tell about from the beginning that it comes with a 15 connector. There is a suction port above cuff suction port. It comes with a pilot balloon and a spring-loaded one-way valve. There is a PVC tubing. Okay, and an air-filled cuff which typically contains around 10 ml. And also know regarding the inner diameter of the tube. Also mention the inner diameter of the tube. So you might be asked regarding the Murphy's eye. So the Murphy's eye, it is another opening. If the primary opening is occluded, then ventilation can still occur with this Murphy's eye. So the how to introduce the endotracheal tube, you might be asked. And you might also be asked that if you, in case of a difficult airway situation, if you're not able to give an endotracheal tube, then you go ahead with the supraglottic airway device. I'm not going to go into the details of it, but please go up and read the different classification of the supraglottic airway devices, the advantages of one over the other. Okay. Subsequent questions could be, what is the difficult tracheal intubation regarding the DAS guideline? Okay, that one might be asked. Difficult airway assessment mnemonic. Okay, regarding the rapid sequence induction, what is the 7 P's of the rapid sequence induction, and what is modified rapid sequence induction, where some positive pressure is given, unlike that of a rapid sequence induction, and other drugs uh, like other than succinylcholine can also be used. So please note the difference between the modified rapid sequence induction. Okay, other potential questions could be delayed intubation. Okay, drug assisted intubation. Our next question is the oxygen delivery systems. So the various oxygen, when you have to describe, please start by describing whether it is a variable performance device or it is a fixed performance device, how much flow all of these give with the respective FiO2, okay, the comfort level, okay, humidification, whether it provides or it doesn't provide. Regarding Venturi, one needs to remember that it comes with the color coding for the different flow and the giving the different FiO2. And one also needs to know and mention regarding the mechanism of Bernoulli's principle or the entrainment effect, which occurs that if the pressure at the constriction falls below the atmospheric pressure, the air is entrained. The greater the constriction, the larger the drop in the pressure and more air is entrained. This is the nothing but the Bernoulli's principle or the Venturi effect in case of Venturi mass. So thus one might be asked. Coming to our next instrument, which is the tracheostomy tube. So tracheostomy tube, please know the parts of the tracheostomy tube. We have the inner cannula, the obturator, the flange, the outer cannula, the cuff, the pilot balloon, and sometimes it also comes with a decannulation plug. The benefits of tracheostomy, what are the evidences for it? Okay, different types of tracheostomy tube techniques one needs to remember. Where is it used? In case of prolonged intubation, facilitation of ventilator support and weaning, upper airway obstruction, inability to intubate, in case of adjunct in a major head and neck surgery, trauma management, airway protection. So we might also be asked regarding the technique of decannulation and when the patient is decannulated. So we need to know the technique of decannulation of the tracheostomy tube. Okay, manual tube occlusion, speaking valve might be used. All right, more than 12 hours. If it persists, then tube capping is done, followed by decannulation more than 24 hours. It might be a success, it might be a failure, and one might need to go up with a recannulation as well. Okay. When we talk about complications for any kind of instrument, even whether it is an IABP or a tracheostomy tube or anything, please know that you need to talk about, you need to systemize your answer by telling early complication or late complication, or pre-procedure complication, sorry, intra-procedure complications and post-procedure complications. So whenever you're answering, divide your answer in a systemized manner in the exams. Okay, and the evidence for the tracheostomy comes with the TrackMan, the set.2, and the trachus trials. So that might be asked. Coming to the heat and moisture exchangers, it is an artificial or passive humidification device which comes in with a small dead space of 30 to 95 ml. Okay, filters can be added here, either hydrophobic or hydroscopic filters, and there is a central layer of foam or paper embedded with a hydroscopic salt, that is calcium chloride. It has a filtration efficiency of more than 99.9% and a humidification efficiency of more than 30. A connector is used for the placement of this. Where is it used? To provide humidification. Okay, in case, however, in case of patients with uh, too much of secretions, tenacious secretions increase airway resistance, it worsens the dead space. Okay, there might be blockage which might be unrecognized. So it is not appropriate in case of use of large air leaks. Subsequent questions for regarding HMEs, following HMEs could be: what are the different types of humidification technique that we have, whether it improves VAP or not. It cannot be regarded as a tool for prevention of VAP, and the definition of absolute humidity and relative humidity might be asked. This arterial line I'm not going to cover. Dr. Sanant has covered it very nicely. So we will skip this. Next, this instrument, which is nothing but your vibrating mesh nebulizer. Please talk about the principle, that is a vibrating mesh plate with micro holes. Micron size aerosols are introduced, and the driving source being the electrical energy. Heat generation is minimum and the particle size consistent 2 to 4 microgram can be delivered. Okay, residual drug very low in case of vibrating mesh nebulizer. Please know the advantages, the disadvantages. All right, and the efficiency, it has a 90% drug delivery efficiency compared to that of jet or the ultrasonic nebulizer. So placement might be asked regarding the mesh nebulizer as well as jet nebulizer, and one needs to know the placement, that is between the mask and the leak port in case of NIV. And in case of invasive ventilation for jet nebulizer, it is kept 6 inches before the Y connector of the inspiratory lip. In case of mesh nebulizer, it is kept upstream of the humidifier. Okay, so these two things one needs to know. Subsequent questions could be: what are the drugs which are used for these nebulization? Or you might be asked regarding nebulized antibiotics. You might be also asked regarding the any evidence which we have, that is the Amincal trial regarding nebulized antibiotics. So this could be the subsequent questions. Coming to this instrument, which is the Sengstaken Blackmore tube, it is used as a for temporary control of massive upper GI bleed from the esophageal or the gastric varices, which are unresponsive to the medical or the endoscopic therapy, or as a salvage therapy in case of life-threatening hemorrhage. When we have to describe the parts, it consists of 3 ports: the gastric balloon port, the gastric aspiration port, and the esophageal balloon port. The gastric balloon port is inflated first. It is usually 250 to 300 ml in case of Sengstaken Blackmore tube. We have another tube, which is the Minnesota tube, which comes with 4 ports, and the inflation is around 450 to 500 ml. Advantages: it helps with rapid control of the bleeding in unstable patients, and can be life saving when other interventions fail. However, it can result in perforation, it can result in rebleeding. It is non-suitable in case of non-variceal bleeding, and one has to be very careful while placing it. It can cause airway obstruction and mucosal necrosis as well. Regarding this device, that is the CRRT device, what are the potential questions that you can be asked? First of all, if you are given this kind of a system, okay, one needs to note the basic components that comprises of the CRRT system, which is the system itself, the warmer, the vascular access, anticoagulation solutions, and the hemofilter. So these, and what are the parts of this? We have the 3, it is divided into 3 units: the communication unit, the flow control unit, and the fluid control unit, and the various uh, uh, pumps one needs to know. So subsequent questions what one can be asked is: what are the different types of dialysis that we know? Okay. What are the different types of CRRT techniques that we know? That is the CVVH and the CVVHTF or the CVVHF. What is the mechanism? That is the diffusion versus convection mechanism. That also is a potential question. And which renal replacement therapy is used for what kind of molecules? So what are the molecules we have? The small molecules or the electrolytes like urea, creatinine. So the best for small molecule clearance is diffusion technique, and best uh, for a large molecule clearance or the mid-size molecule clearance is filtration technique. And indications for renal replacement therapy, that is the severe metabolic acidosis, refractory hyperkalemia, hypervolemia, so not responding to other medications, in fact poisoning cases. All right, so these indications one has to know by heart. Uh, Even though they are not usually asked in the instruments, but we might still be asked regarding any part of this ECMO machine. Okay, so the basic one needs to know is you might be asked to draw this even in your vivas, even while when you have a long case like an ARDS, this you might be asked to draw. So VA and VV ECMO, the difference between the VA and the VV ECMO, VA ECMO, it maintains the pulmonary blood flow, it increases the mixed venous oxygen. The VV ECMO, VA ECMO, it decreases the pulmonary arterial pressure and it helps with the cardiac support. VV ECMO does not provide cardiac support, it does not assist in the systemic circulation. Okay, so the differences one needs to know from the drainage cannula to the return cannula, what are the components, the blood flow, the oxygenator, this also one needs to know. Indications of the different kinds of ECMO, okay, and the complications, please write, say systematically the neurologic, hematologic, pulmonary, device related, cardiac, infections, renal, and some VA ECMO specific complications also might be asked. So this is the last of the instruments that I'll be discussing. So you might be given this device, okay, which is your the ICD device. All right, the intercostal drainage device. And the intercostal drainage device, one needs to know that there is a drain catheter, there is an integrated one-way valve, okay, and it comes in two forms. You might either sometimes there is a basically a trocker technique, or it might be a direct technique as well with a drain catheter and holes. Okay. So whenever you're given this kind of an instrument, you will be asked to draw the ICD system. So when you are drawing the ICD system, you have to draw these three bottles. The first one being the fluid trap or the collection bottle. The second one being the water sealed bottle on the underwater seal. And the third one being the suction control bottle. And the maximum negative pressure that is generated by this suction is equivalent to the distance from the vent tube below the water line. Safety features: the volume in the water in bottle 2 should exceed half of the patient's maximum inspiratory volume, and the drain should stay at least 45 centimeter below the patient. Clamp only when moving. Please do not clamp otherwise, as it might result in tension pneumothorax. Know the indications and know the complications. Okay, I think I have taken a lot of time, and I would like to move forward with this. I hope I have covered most of it regarding the drugs, especially. Uh, it is very difficult to cover in a 45 minutes class, but we'll move on to the next speaker, which is Dr. Priya. And it is very difficult to study everything. Please mention everything systematically. That's my only advice to all of you all. Thank you so much.